Okay, good morning. Thanks, everyone. Thanks for those of you joining us virtually. We're going to get started. It's my pleasure to introduce the speakers today. This is a joint oncology grand rounds with the Global Oncology Program here at Queen's and our dear friends and colleagues at Pallium India. I first encountered Pallium India when I was living in Kerala on a sabbatical now many years ago, and was introduced to someone who was referred to as the best palliative care doctor in India. And I met Dr. Raj Gopal, who has since become a very dear friend and colleague. And then fast forward a few years and was the initial and first adjunct professor of global oncology here at Queen's, where he's given an honorary appointment. And this speaks to the huge impact that Pallium India has had on the delivery of palliative care, not just in Kerala, not just in India, but globally, as really thought leaders in bringing together clinical care, policy, education, and research to provide compassionate care and easing of suffering for people regardless of where they live. And so over the last 7 or 8 years, we've had a very productive, dynamic, bidirectional relationship with our colleagues in Kerala. We've undertaken a number of research studies, educational initiatives, and policy projects, and you'll hear about some of that today. And so without further ado, I'm going to introduce our first speaker, Dr. Sunil Kumar, who will be speaking to us from Trivandrum. Sunil is the additional director of the Trivandrum Institute of Palliative Sciences, which is the clinical operations base for Pallium India. He has 20 years of experience in the field as a clinician in palliative care and has had major contributions both in leading education as well as research and policy initiatives in Kerala. And Dr. Sunil Kumar, I'll hand over to you to speak about a very exciting development, which has been a joint partnership between Pallium India and the Queen's Global Oncology Program over the last year. Dr. Sunil, over to you.
Thank you, Chris, and good evening, everybody at India, and good morning, everybody at Queen's. I'm going to present a new educational program, which is a joint collaboration with Queen's Global Oncology and Pallium India, that is Global Fellowship in Palliative Medicine. So the talk of the objectives are to understand the background of starting Global Fellowship in Palliative Medicine. What is the process of formation of curriculum? Design of the course. What is the profile of the first cohort of GFTM students? What is the present status of the students? Then feedback or impact about the course. So why did we start such a course? So the most important thing is that in India, palliative care coverage is very, very less. It is less than 4%. And one of the main reasons being scarcity of trained doctors and nurses in palliative care. And we have various courses available in India, which most of the courses last for from 10 days to 6 weeks. And a few centers provide this course. And then we have specialization in palliative medicine, which is a 3-year course, but thousands of undergraduate students compete for this course, and the intake would be about 30 students per year. Then 1-year fellowship is run by some institutions, 2 or 3, and this is for mostly online courses. And considering this, many of the students has expressed a need for a long-term course because they told the short-term courses does not equip them to manage the complex needs of the patients and families. And they also told that they are unable to take absence from work to do a 1-year or longer courses. So that's about India. And what about the situation in low and middle income countries? WHO says the training for healthcare professionals in palliative care is limited or non-existent. This is about all the countries, but when we come to LMICs, it is often very, very less. And we also know that 80% of the people who need palliative care, they live in low and middle income countries. And then most of the guidelines or most of the research is from high income countries, and these low income countries are they are following the guidelines which are made by the high income countries, which may not be the ideal situation. So considering all this, we started a hybrid course for GFPM, which consists of mainly the theoretical sessions delivered online with a 1 month hands-on training. So now we come to the objectives of Global Fellowship in Palliative Medicine. It is to provide an overview of practice of palliative care globally with special focus on low and middle income countries. To facilitate research and quality improvement programs in palliative care, to impart attitude, knowledge, and skills for practicing palliative care in cancer and non-cancer illness, and to ensure understanding of the ground realities of elements of suffering of people with serious health-related suffering, and to find out the possible solutions which are practical in case of low and middle income countries. Then the process of formation of curriculum. We conceived the idea of starting a new course during November 2021, and then we selected topics which are suggested by the experts, and also looked on the objectives of our course. Then we had multiple interaction between faculties of Queen's Global Oncology and Pallium India. And then at the end of November 2022, we finalized the curriculum. So I would like to thank Dr. Scott Berry, Dr. Christopher Booth, and Dr. Jean Matthews, who actually helped us a lot in running this course. And I would also like to thank Daniel, who actually coordinated all of the meetings. And what is the course structure? So this course is divided into 4 parts: foundation course in palliative medicine, master class in palliative medicine, advanced course in palliative medicine, hands-on training, which altogether constitute global fellowship in palliative medicine. The foundation course in palliative medicine is a 20-session basic course of palliative medicine, which is delivered online. It consists of 1 hour theory with 30 minutes of case presentation, and this is assessed by 5 sessions of multiple choice questions. Then master class in palliative medicine. This includes specialized topics, and this is again assessed by 10 sessions of MCQs. Then we have 1 month of clinical posting or hands-on training. Then there is a self-directed advanced online course in palliative medicine, which has 33 modules, and the candidates are assessed with 32 sessions on MCQ. Then coming to the profile of the first cohort, we have fellows from 5 countries, which includes Dubai, Nigeria, Trinidad and Tobago, UK, and India. And most of the participants are from India. Then the level of medical education, 11 fellows are undergraduates in medicine, and rest are postgraduates. Then 16 of them have done some courses in palliative medicine, and 9 has not done any courses. And you can see most of the fellows, the age is between 31 to 40. And their involvement in palliative care, 18 is working in palliative care, either part-time or full-time, and 7 has no involvement in palliative care. The present status of the cohort is the foundation course in palliative medicine is completed by 24 fellows, and master class in palliative medicine, 10 assignments, they are completed by 18 fellows. Advanced course in palliative medicine, which is a self-learning module, which is completed by 24 fellows. And these are the glimpses of hands-on training at Pallium India, where they see patients not only in inpatient unit or patient units, but also they go and visit patients at home. So coming to the feedback or impact of the course. This is an interim feedback, and you can see at the start of the course how many of them had skills and knowledge, or their confidence about skill and knowledge about palliative care. One told it is excellent, and there were nobody told they have very good knowledge. 9 told it's satisfactory, and at present, 4 says they have excellent knowledge, and 10 says very good knowledge. And there is nobody now in the fair or poor status of palliative care knowledge. Then if you look at the confidence level in mentoring or training any topic in palliative care, before the course, you can see their confidence level varies from 1 to 10. But now you can see all have confidence level 7 or above. And the feedback about the course content, most of them strongly agree with the learning objectives were clear, program content, program workload, and learning materials were useful. Feedback about presentations, speakers, and organizing team. Almost all of them strongly agree with presentations were clear and organized. Speakers stimulated interest in topic. Organizing team was available and helpful. Assignment gradings were prompt and help enhancing knowledge. And I'm taking two of the experiences of our fellows. One fellow, Dr. Punitavadi, she was able to open a new palliative care ward at her hospital. You can see the inauguration. And the other one, Dr. Pushpu Singh, she opened a pain and palliative care clinic at her hospital while doing this course. And I would like to end this with this testimonial. Hi, I am Dr. Pushpu Singh. I am working as a consultant anesthesiologist at Utkal Hospital, Bhubaneswar. Choosing palliative care as a part of my specialty is the best decisions I have made, and choosing Pallium India as my training institute is the second best decision. Working under the guidance and mentorship of Dr. Raju Gopal is a blessing. I had a fulfilling journey at Pallium India, where I found everything like knowledge, skill, guru, and friends. Most importantly, I learned a very basic yet rare human behavior, that is compassion. And I learned this from each member of Pallium, starting from housekeeping staff, drivers, volunteers, sisters, and doctors. I can assure that no other institute can provide such an elaborate practical knowledge about palliative care as Pallium India does. Another important mention is the learning module. It's interesting, simple, yet full of relevant content. Last but not least, Pallium India and Palliative Care taught me how to become a good doctor. I'll be grateful to whole Pallium team and congratulate them for creating the Global Fellowship Program. Thank you for your patient listening. Thank you everybody at Queens for helping us with this course.
Great. Thank you, Dr. Sunil, for that amazing overview of a huge accomplishment. Just to kind of drive home some of these concepts, you know, India, which is a country of 1 billion people, the formal training seats for palliative care is somewhere in the range of 20 or 30 per year. And so with the launch of this program, we've doubled that output. So Dr. Sunil and colleagues in Pallium have now trained 25 new palliative care doctors that will join clinical groups as of January. And the momentum's building. And this was all funded largely funded by the Nair family in Toronto, who organized a gathering of their friends and community members. And we had a dinner last year where we talked to them about the work done by Pallium India. And it's amazing to see what was, you know, a substantial investment, but what the human impact of that can be. And so the plan is to continue and to actually grow to either 40 or 50 seats in the coming years. So this is making a huge impact on the delivery of palliative care in India. So congratulations, Dr. Sunil and everyone there. And now we're going to hear the second speaker, Dr. Sreedevi, who I've also known for many years, who has both a clinical background and both in education and policy. But her main role in this context is as an educational lead at Pallium India. And Dr. Sreedevi will tell us about another extremely ambitious educational program that the Pallium India team is leading with support from the educational scholars within the Global Oncology program here at Queens. Dr. Sri, over to you.
Thank you, Chris, and thank you everyone for listening to our programs that we are doing collaboratively with Queens. So as Chris mentioned, this is another ambitious program that we do in palliative care. I know Dr. Sunil touched upon the background, but Chris re-emphasized the need of palliative care. And the access to palliative care is very, very less. And that is very limited to most of the time to end-of-life care or people with cancer. The other illnesses which is covered under palliative care is still under discussion or in its very nascent stage. And we know that I don't need to introduce this concept to this group, but to touch upon the basics, WHO Public Health Strategy for Palliative Care emphasizes on education along with other headings like implementation, availability of drug and policy. So unless you have education and training in place in terms of media or public advocacy, curricula, or training the family caregiver, training the healthcare providers as much as possible, it is very difficult to implement palliative care aspects in a public health way. And what happens in palliative care and medical education? So till 2019, palliative care is never taught in any of the medical education or nursing education as such. So people hear about palliative care once they become doctors and they undertake these short courses, as Dr. Sunil mentioned, 10 days course or certificate course. And so that is something you have to unlearn a lot of things. You don't learn about pain management. You don't talk about symptom management or end-of-life care or treating the person. None of the basics of palliative care or communication skills. So in 2019, palliative care is introduced into the medical curriculum, and billions of people in the country, only 30 specialists getting trained each year. And we are talking about addressing serious health-related suffering of around 10 million people at any point of time. And this 30 specialists are created every year, which is very, very far from the actual reality. And we have around 100,000 doctors, young doctors practicing or completing their undergraduate medical education each year to the existing pool of more than 1 million doctors who are already practicing without any prior training in pain management or palliative care. They have not even heard or taught pain management or the basics of WHO analgesic ladder or the term palliative care. So what changed? The National Medical Commission is the body who manages all the medical institutions in India. And National Medical Commission decided to introduce two important concepts into the medical education in 2019. One is competency-based medical education, and second is 8COM. 8COM includes attitude, ethics, and communication skills. So till 2019, the communication skills, ethics is not at all included in the curriculum. So National Medical Commission included these two concepts in 2019. And when they revamped the old curriculum, they included so many topics which comes under palliative care, around 20 modules which covered the concepts of palliative care as well as end-of-life care and communication skills. And what they have done is that they have distributed all these modules starting from the foundation. The foundation is the time when you just enter a medical school. You have not actually started your medical education, which is the first introductory part or period into the medical school. So they started from the foundation course to their internship across various specialities. But what happens is that although they are told to teach these topics, only 5% of institutions in the country has actually a palliative care delivery in place. So this is a very new topic. There are no trained people. There are no self-service delivery to actually model this for students. So that is where we thought it is very important to create a curriculum, to create experts who can teach the students about palliative care. So what we did at that time was we created a national experts group and we developed resource materials, in which includes trainer's guide, which include presentations, videos, whatever is needed for training students. It's like the training docket, which has all the essential resource materials for teaching. And there are around 700 and more medical colleges, medical institutions in our country. So we sent out communications to all the medical institutions telling that, see, we have all this thing ready. We know that you don't have trained people or service delivery available in your institution. We have all these modules ready for implementation. We can use this. And through those communications and through various nominations, we so far trained 188 faculty members from 89 institutions. I completely know that it is 89 out of 700 plus medical institutions that we are talking so far. And what we have done is 2-level training program. The first level, we teach them the basics of palliative care. The target audience are faculty members of medical institutions. So we teach them the basics of palliative care and pain management in the first level. And the second level, they go into a little bit more detail into faculty development, them to more of teaching techniques, how to actually teach these topics. One of the biggest concerns were the sensitivity of the topics, sensitivity of the conversations. How can you talk about end of life care or serious health related suffering to medical students? So in the second part, we addressed how can you effectively teach or deliver these topics to medical students. And we have developed and all these were done in discussion with the Queen's team from the beginning. I think we started the conversations years back, like how to go ahead, how to create the curriculum, how to standardize these modules, etc. And then recently we came up with the evaluation of the particular program. We developed pre-test, post-test, knowledge retention surveys and behavior change surveys, and a few focus group discussions. The focus group discussion will give us an idea about, okay, we are giving all this knowledge to you. I mean, what is your plan for implementing this in your institution? Or what do you think will help you to implement this? What more do you need from our side so that this can run smoothly? What is the expected impact of this program? As I told, this is a very ambitious program in terms of palliative care delivery in the whole country. This has the potential to change the face of palliative care in the country, because we're talking about training 100,000 medical students each year. So whoever is getting trained in the medical education will have a basic understanding and knowledge of palliative care. And irrespective of whatever specialty they take, they can be an oncologist, they can be a pulmonologist in future, they can be a general medicine person, or they can be a pediatrician. They can have the palliative care approach irrespective of their specialty. And this will in turn improve the access to pain medications as well as palliative care in the country. So rather than waiting for them to become doctors and then give them short-term courses, we are aiming them as early as possible, giving an idea about palliative care so that they can integrate in whichever specialty they are in, so that the access to palliative care is improved to a larger extent in the country. Yes, we are still struggling with a lot of, because the program is huge and the country, the need is huge. The number of medical institutions is increasing every month. We're struggling in terms of implementation. Okay, we are teaching everything to the faculty members. How far they are going to implement this in their own medical institutions? Are there any administrative barriers? Are there any issues with reception from the students? Are they enough equipped to teach these topics? And evaluate the program. And of course, we need to publish this so that people are aware that this kind of program exists, or this is how we should get trained and we should teach palliative care. So that advocacy is also very, very important. As of now, we don't have any funds for this particular program. So we are doing all the program online, and that definitely affects the quality of the program to some extent, although we try to make it as interactive as possible. So once we have funds for this particular program, we'll be able to do it in person so that it can have more acceptance as per the feedbacks. And the third part is approval by medical universities. And all these institutions functions under universities in each state. So once the university is convinced that, okay, this is going to change many practice, or these are modules which can help them to integrate palliative care in their education, that will be easy to integrate into all the medical institutions under their authority. So that's the third thing that we are working on. And that's all from my side. Thank you so much for the patient listening in the morning.
Thank you, Dr. Sree, for an excellent lecture. Again, giving our audience here an idea of the huge scope of work that's being undertaken by Pallium India and that we're privileged to be a part of. And I just want to acknowledge as well, there are many clinical faculty here in Kingston, both in the Department of Oncology as well as the Division of Palliative Medicine, who have graciously been involved as teachers and mentors and scholars to help support this. So it's been actually a lot of fun for us to engage as a team with our colleagues in Pallium, India. So our third and final speaker is our very own Dr. Jean Matthews. Jean is a palliative care physician here, but actually it will tell, I think, a very interesting story about bridging of two worlds, because Jean was born in Kerala, had a career path detour a few times, landed in Canada, and then landed in Kingston. And the interesting part is Jean and I overlapped in Kerala. We probably just missed each other by literally a few weeks in 2016, and both of us have these kind of profound career moments. And I'm not overstating it when I say that my time with Pallium India in 2016 was the most profound experience of my clinical career. It's an amazing contribution to medical care and easing of suffering that our colleagues do in Kerala. And so Jean's going to tell us about a story about how we're trying to bring lessons we've learned from our colleagues in Kerala back here to Kingston. Over to you, Jean.
Thanks, Chris. So as for those who don't know, I'm Jean Matthews. I'm part of the Division of Palliative Medicine at Queen's. And as Chris mentioned, I was working in palliative care in India before I came to Canada for further training. So I actually know Sri and Sunil from my time working in India. And as Chris mentioned, it's quite fortuitous. In 2016, I was working as an anesthesiologist, and like so many, maybe hundreds or thousands of other anesthesiologists and other specialists in India, I heard a talk by Dr. Rajagopal, and then I made a visit to Pallium, India, where Sri and Sunil work. And then, it was a profound moment in my career as well, as Chris also mentioned, where I made the switch from anesthesia to palliative care. So it's a real full circle moment for me to join Queen's and the Queen's Global Oncology community, and work with Pallium India again as part of this partnership. So you've heard a couple of very amazing, ambitious educational projects that our partnership is implementing in India. So now we're going to focus on something more local. A project that our partnership with Pallium India is implementing here in Kingston. It's called the Kingston Kerala project, or more locally here we call it the KinCares project. So in terms of disclosures, our team won a CMO Innovation Award to develop this project. A couple of other disclosures not relevant to this. So we know that patients with life-limiting illness want to remain at home as long as possible, but as their disease progresses, they have more challenges with their activities of daily living. They experience social isolation, and formal healthcare services like nursing and personal support workers, they're not the best equipped to meet some of these needs, and also they're quite limited, especially in our region. And our region has one of the highest rates of unplanned ED visits and hospital admissions in the last year of life. So patients are often forced to move to acute care due to failure to cope at home. So what can we learn from our partners in India? So this is the neighborhood network for palliative care. It's a model of volunteer-led community palliative care, which was developed in Kerala in the 1990s. So basically, community-based palliative care programs identify and train volunteers in a neighborhood or village in informal caregiving. And these training courses cover the basics of caregiving activities. And these trained informal caregivers provide an added layer of support to patients to address their social and emotional needs, and also supplement the care provided by their palliative care programs and serve as a kind of a navigator role as well. So Chris has already mentioned the long-standing partnership between Queen's and Pallium India, and Dr. Rajagopal was kind of formally appointed as the first adjunct professor of global oncology at Queen's. So this project represents an exciting example of bidirectional global health learning, where the team at Queen's were trying to bring the community-based palliative care program from Kerala to Kingston and measure its implementation. The other kind of global movement that has informed this project is the public health approach to palliative care. So this basically states that caring for people with life-limiting or serious illness should not be exclusively the domain of hospitals and healthcare providers. It should be the responsibility of the community and everyone in the community. So the social isolation and spiritual crises experienced by patients are poorly addressed by formal healthcare services. And so the idea of mobilizing the community to support these needs for people with serious illness led to the global compassionate community movement, also in the 1990s. And the Kingston chapter of Compassionate Communities has been operating since 2017. And in fact, we partnered with them for this project. Just a side note, the World Hospice Palliative Care Day celebrated last Saturday, and the theme for this year is Compassionate Communities Together for Palliative Care. So very relevant to the work we're doing. So our objectives are, we wanted to develop, implement, and evaluate an intervention to improve healthcare delivery for people with life-limiting illness in Kingston by connecting them with trained volunteers in informal caregiving. And this model is informed by both the Neighborhood Network of Palliative Care, as well as the Compassionate Communities movement. And our research question is it feasible and acceptable to bring this model from Kerala to Kingston? So the basic approach is we're gonna recruit, or we are now recruiting volunteers in the Kingston community. We have a project coordinator who's reaching out to various community volunteer organizations and other community sources to recruit volunteers. These volunteers will undergo training. So Pallium Canada offers online training for free for informal caregivers. So they'll undergo online training, and then they'll be matched with patients with life-limiting illness who are facing social isolation, who are connected with our Queen's Palliative Care team. Matching will be based on geography, based on common interests, and things like that. What we're measuring is the implementation, the demographics of the patients and the volunteers, what is the frequency of visits, what are the activities that people engage in during these visits. We're measuring feasibility of recruiting 40 patients and 40 volunteers over the first 6 months, and feasibility of 80% of volunteers completing the required 3 visits per month for 3 months. That's how we're defining the feasibility of this. And then acceptability, so we're doing interviews and surveys of patients, family, and volunteers. So this represents a low cost and high value innovation. It's if we're able to prove the feasibility and acceptability of it, we'll be well positioned to scale this up regionally with several chapters of compassionate communities across the country. There's major potential to expand this. So where we are right now, we got REB approval in August, and now we've, in the last 2 months, started volunteer recruitment. Our study coordinator has reached out to Compassionate Communities Kingston. We're already partnered with them, and through them, through the Seniors Association of Kingston, through the Queen's Retirement Association, Lions and Rotary Clubs of Kingston, neighborhood association. So Chris, lives in the Reddendale neighborhood, and he's been distributing flyers in the neighborhood. We've reached out to faith-based organizations. You might see our posters in your local library. So these are the kind of sources we've reached out to. In the last 2 months, we've had 16 people express interest. About 10 of them, Melissa and I, Melissa's the study coordinator, and I have completed interviews. And now they're at the stage of doing the online training, doing the criminal record check. And we have 3 people who have completed all of that, and they're basically in the volunteer pool. We're hoping to build the pool to about 10 volunteers before we start the next phase, which is recruiting patients, just so that once we open it up to patients, they don't have to wait too long to be matched with someone. Most of the volunteers are so far coming from Compassionate Communities Kingston. They're all retired older adults. Their main interest in volunteering is they're interested in giving back to the community. Some of them have experience with family of palliative care, and so they find this to be a valuable service. Those are kind of the main reasons people have stated for why they're volunteering with us. We have noted that in the last 2 months, there is a bit of a dropout in, out of the 16 or so people who expressed interest, getting through the interview, getting through the online course, getting through the criminal record check, and finally entering the pool. There is a dropout in that number, and this is not exclusive to us. We spoke to other Queen's research teams who are doing volunteer recruitment, community engagement projects, and they've also had similar issues with dropout. So we're now thinking about how to expand our pool, advertising, and spreading the word and things like that. So we're meeting with the Queen's communication officer to look at avenues for media outreach. So we think this is a good kind of human interest story that's developing. So is there a way to kind of get the word out more? And so part of the presentation today was, if while you're hearing all this, you can think of people in the Kingston community who you think are a good fit for to volunteer for this, just reach out to me and we can share the material and how to recruit volunteers and things like that. The other thing we've been looking at when we started this, we started with the assumption that to form a good companionship, you need to be in the same generation or age group. So we've started with that, and all of our patients are older adults. And so we kind of restricted ourselves to retirement groups, seniors communities, older adult volunteer groups, because we thought that is required. But members of our team are also hospice volunteers, and they've said that that's not necessarily the case. You can have intergenerational companionship, and we know in our experience in India that certainly there are student volunteers in these in the neighborhood network for palliative care. There's research in Canada about intergenerational companionship and how that addresses social isolation for older adults. So recently, a professor from St. Lawrence College had reached out to us, and the professor from St. Lawrence College had reached out to us, and they have a pool of students who are interested in this project. So we've been in talks with them to see if we can partner with them for student volunteers. And this sets up a nice kind of side experiment, which is, age-matched companionship versus intergenerational companionship. What are the kind of differences in terms of feasibility? Are one group able to make those visits more regularly? Is the quality of the companionship different between these two groups? So it's an interesting side project that has come out of this work. This is our flyer. So if you go to your local library, you might see this up on the community events page. If you'd like a copy of this, just reach out to me, or you see the King Cares study email below. This is for volunteer recruitment. So next steps, once we get a good pool of volunteers, we'll start recruiting patients. We're including ambulatory patients with life-limiting illness, cancer or non-cancer, with an expected prognosis of more than 3 months. For this pilot phase, we're excluding people who are at an end-of-life stage, and those who are facing social isolation, obviously. And there's no strict criteria for that. If you feel like someone's lonely, we would include those people. Exclusion is people with known violent behavioral alerts, active substance use, other safety concerns, because volunteers are essentially going into a stranger's home. The strategies we're using to mitigate that safety risk. So obviously there's an informed consent process. Our study coordinator, Melissa, will make a home visit to each of these people before the first visit from the volunteers. Some of the volunteers have requested Melissa be present for the first visit, so we'll obviously accommodate that. Some of our patients will come from clinics, so either palliative care clinic or the division of MedOnc or RadOnc, or as long as they're connected to palliative care in some way, we're going to accept them. So if they're connected to the clinic, Melissa will make a first visit. If they're connected to our community palliative care team, we're already making home visits, so we'll be aware of some of those safety flags. details on the patient recruitment process to follow because we're still building the volunteer pool. But once we have that, I'm going to request all the division chairs for the palliative care, Medonc, Radonc, to give me 5 minutes, me and Chris, to kind of speak about this project. What's the process for patient recruitment and things like that. All right, so that's at the end. This is a study email and my email below if you have someone who you think would fit for this. Now we'll open it up, I guess, to questions for the whole team.
Great, thanks, Gene. Gene's done a huge amount of work leading this, and it's been a really rewarding project to see evolve as an example of bidirectional learning between two health systems. So we'll open up to questions from the audience here in person or on the chat. I might start with one question for Dr. Sri. Can you, Sri, in your engagement with these dozens and dozens of medical schools, can you give us an idea, where are the greatest barriers? Is it with the medical school leadership getting in the door? Is it with the professors trying to teach them things that they need to learn to be able to teach? Or is it going to be engaging with the students? I imagine there's different challenges at different levels. Can you give us an idea of that, please?
Thank you for the question, Chris. I just attended one of the faculty development program session just right before this this program. So I happened to hear the participants sharing the barriers. So first of all, they feel, even the administrators or faculty members or even students do not feel palliative care as an important topic. I mean, they would prefer to study a question that is going to appear in a question paper which can score 10 marks, which can be from surgery or internal medicine, not from palliative care, which is mentioned among many other treatment modalities. So it doesn't carry that weightage. So it is not really attractive to people who are teaching and for students who are learning.
Great, thanks, Sri. And if I may, one more question, Dr. Sunil. Can you give our audience an idea of the level of interest for year 2 of the fellowship program? Where are you hearing from potential fellows? Where have they applied from across India, across other countries? What has been the response for the call for applications for year 2?
Yeah, so compared to previous cohort, I think this year when we called in for application, we have a lot more numbers of application. And that's also from various countries, like lower middle income countries, Ethiopia, Sri Lanka, Nigeria, Uganda. So I think it is getting more popular among others. And also another important thing is that last year we had more of participants from Kerala, but this year we have a lot more fellows applied from other states of India. The numbers from Kerala are less. So that's what we want, because in other states, the penetration of palliative care is very, very less. So we would like more fellows to apply for fellowship from other states than Kerala and from other low middle income countries.
Great, thanks, Dr. Sunil. Any questions here in the audience or on the chat? Give a few minutes still. Tara.
Yeah, so this is really inspiring what is happening with the fellowships in India and the work you're doing, Gene. One of the things that comes to mind is that patients, caregivers, or family members sometimes need some of the skills that you're training the volunteers. I'm wondering if there's possibly an opportunity to also offer some of the skills, because some of these family members learning these basic skills, or even how to engage and discuss these difficult topics, might be very helpful, because we do see that as an issue in our population, and this would broaden the reach maybe a bit more.
Yeah, Dr. Bates, that's a great point. I mean, I think the approach to training will be a bit different. It certainly exists, the educational modules for this. So for family caregivers, we would talk more about kind of personal care. We talk more about, I mean, Pallium Canada has a lot of modules about, usual kind of daily personal care activities, how to train and things like that. Whereas an informal caregiver would not be taught and are not expected to do any kind of direct personal care activities. It's more social support. But I agree with you. There's definitely scope for expanding this. It might be kind of a side project we do, because the approach would be a bit different between what we expect from personal family caregivers and an informal caregiver who's not family, but for sure there's a need for that as well.
Yeah, I could see that we could include that in some of our education to patients and families, because this cohort of people is also maybe the volunteers of the future for your group, because many I have from the patient family advisor group saying, you know, I've had this experience, maybe I can help somebody go through the cancer journey as well, which sounds like this is similar to what
the people were getting. And one of the lines in our volunteer recruitment flyer is caregiving is beneficial both for the person receiving it as well as the person giving it, because like you said, you know, it's something we'll all need, our families will need at some point, so for sure.
Great, thanks, Tara. Dr. Chris Frank has a question for our colleagues in India. Dr. Frank is a physician in Kingston who practices geriatric medicine and palliative care. He's also a well-known mandolin player. Chris, what's your question?
Yeah, thank you very much. I wanted to just ask, when I've worked abroad briefly, one of the challenges in palliative care was actually policy and like more government related policy and say access to opiates for, you know, for pain management in palliative care. I'm sorry if I missed it, but has that been a big challenge to kind of you trying to launch your excellent educational efforts?
Dr. Sunil or Dr. Sri, do you want to tackle that? I know Palliative has a huge amount of work in that space.
So this has been a problem in India for many years, and many doctors have not seen even the tablet of morphine for generations. But from 1993 onwards, where we had palliative care started at Calicut by Dr. M.R. Rajagopal and his team, and they have been continuously behind government to change the policy and to make it easy for palliative care physicians to access opioids. So as a result, in 2014, the main law, that is Narcotic Drugs and Psychotropic Substances Act, that was changed in 2014, and now all across India it is easy for palliative care people to access the strong opioids. And Pallium India is actually making more, we are working with stakeholders in every people in palliative care champions in India to make it accessible for them.
Great, thank you very much. And just to go back to my somewhat random comment earlier, I mentioned 1991 just because that's when I finished training, and I had zero for my whole 6 years of training. Information about palliative care just happened to fall into it. But it was really the efforts of individuals that have really changed things in Canada, like to be at least a little bit better. So I salute your passion. So thank you very much.
Thanks, Chris. Thanks, Dr. Sunil. Yeah, just to follow up on that. So that was the first project, the first research study we did together, Dr. Rajagopal and I, was to better understand the population level delivery of opioids in the Indian, or specifically the Kerala health system. So to give listeners an idea of the magnitude of this challenge, and there's been huge strides in the space, largely led by Dr. Rajagopal and the team at Pallium India, to increase access and promote policies that facilitate appropriate use of opioids in the Indian health system. But if we look globally at peer countries, not perhaps Canada or the US or Australia, which have a massive overutilization of opioids in non-cancer chronic pain. But if we look at some countries in Europe where they have good access to palliative care and they do not have an overutilization problem, the annual per capita utilization of morphine equivalents is in the range of somewhere about 100, 150, 280 milligrams per person. So it's in that range, 100 to 200. Across India, it's less than 1 milligram per person per year. So it's just a staggering difference in access and utilization of opioids. And certainly Kerala, on the basis of the work by Pallium India, is leading the way across the Indian health system, and there are encouraging signs of improvement, but there still is a large unmet need both to access pain relief as well as compassionate care through palliative physicians, nurses, and volunteers. Thanks for that, Dr. Sunil. Any other questions before we wrap up? Well, with that, I'm going to thank the audience, but most importantly, thank our friends and colleagues and partners in Trivandrum, the Pallium India program. We're very grateful as well to our local faculty who are involved teaching and supporting these efforts, to the Nair family for supporting this work through generous donations through their network. And we look forward to the next number of years as we see these very ambitious projects, both in Kerala and Kingston, continue to move forward to ease suffering for patients with terminal illness. Thanks very much, Dr. Sunil, Dr. Sri, and we'll be in touch as we continue our project in the near future. Thanks.
Thank you, everybody.